rotate the bar. It's a measure for the field dependence. It's a kind of static visual dependence. So it became just a square on a monitor screen. It's very different to having the whole field of view tilted. So that's what VR can bring, is bring back the 3D rod and frame test, even with realistic environments. So about the CAT-SIB, CTSIB, so that's the sensory organization test you're very familiar with, like the acuity tests, Neurocom. And this is the CAT-SIB, so with no specific tools. You have condition 1, 2 on the floor, 1, 2, 3, 4, 5, 6 on foam. And for the sway referenced vision, you have this around your head. So for sway reference vision, it's not a bad idea. But to compare, I will go back here, to compare eyes open with with the sway reference vision, it's quite difficult, because eyes open, you have the full view of the room, and sway reference vision, you have a very, very tiny view with something very close to your eyes. So are we really comparing condition 1 and condition 3 in terms of stability with sway reference vision? Or are we measuring the ability to maintain your balance in a large environment or in a very closed environment? I suppose maybe a little bit of both. So with the VR goggles, you can use the same environment in condition 1, 2, 3, 4, 5, 6. You just add foam for condition 3, 4, 5, and 6, and you have all here the results you could have on the sensory organization test. On motion simulator, you can have 360-degree movements for the sway referenced floor. We'll see that after. So after enhancing what was existing, we could develop new tools for other kind of pathologies. So first of all, what was important is to be able to bring optical flow, because when we use optokinetics, we have something that's turning, either horizontally, vertically, rotational. But when we walk in everyday life conditions, when we are in a grocery store, in a supermarket, crossing people, you have a linear visual flow. So that was very important. And that's, I think, really a very important step in vestibular rehabilitation, to be able to bring this 3D, very effective visual, linear visual flow. We can even combine. So again, we can set the transparency. I'm not sure if I showed that. Yeah. So to be able to be very progressive in the rehabilitation, but also we can add proprioception by making it move right, left, up, or down. That's for the motorist disorientation syndrome I told you about. It's patients who cannot drive on the highway anymore. They can drive normally in a city, in the streets, or in small roads, but not on a highway. So maybe I will talk about this another time, but that's very realistic conditions. They drive on the highway, it's a French highway, and they have to pass trucks, to go outside of the highway, and night, day. So it's very, very realistic, and we managed to reproduce the symptoms. And that's, again, key when we try to use the habituation for rehabilitation. Is, for me, it was to hear the patient say, that's exactly what I have when I'm in my car. And now they have an actual steering wheel and pedals, so they really feel like they're driving, and it's a lot more effective as comparing to what I used before VR. Habituation, for being with multisensory, again, there's sounds and actual movements of the patient. So for patients who feel uncomfortable in a crowd, so you see it's a small grocery store, there's a flow of people coming to you. You can set how close they will come to you. They can come closer, faster, and it's quite realistic, because they will avoid you. And here, see, they don't bump into you. They wait until they find their path So you can use and grab products. So again, being uncomfortable in a crowd, especially in a metro or in a closed environment as well. So you go inside the wagon, and that kind of simulations for escalators or travelators as well. That's also for the visual flow and for risk of falls, because when you go out, you have a strong reaction at the end. Fear of heights, for example, acrophobia. So these settings are the worst you can do, but you can set everything, the transparency of the walls, the speed of the climb, of going down, the height, of course. And what's interesting is to have an active rehabilitation. At the beginning with VR, you couldn't move in the environment. So patients staring at that, it works. But it's a lot better to ask them to be actor and like this, to walk on this plank and to put themselves in danger. It's a lot more effective. We can set the size of the plank, so it can be easier. Of course, usually with patient, I start at maybe 2 meters high and not more. So that would be maybe the last session of rehabilitation. And at the end, when it's slowing down, you actually feel this stomach reaction. So you feel the actual movements even if you're not moving. Okay, and now we can even combine VR to computerized dynamic posturography or motion simulator with virtual reality. That's even more interesting because we will have all the movements as well. So that's what the actual CDP will look like. Well, I will show you now is old videos of prototypes. So maybe I will skip that. So you're able to do all the assessments like SOT, limits of stability and everything. And then for rehabilitation, you can start with a fixed plate and add a little bit of movement and control for each plane of movement, the amount of movement. So this is for mediolateral movements only. And of course, it's kind of fun. So for patients, playing while doing rehabilitation is another key to all kind of rehabilitations, not only vestibular rehabilitation, because of the motivation of the patient to come and do the rehabilitation sessions, but also because they're not thinking, I'm doing this, it's dangerous, I could fall, or it could bring any pain or anything. No, they're just focused on what we ask them to do. Here we added bumps, so it's a little bit more difficult. So the patient is really focused on when we ask him to do, and is outside of the rehabilitation room or the clinic or anything. So he goes a lot further to even what you think he would be able to do. Really, they go further than what you can expect while being in VR. So I will show you a few different things here. This is again fixed plate, and I'll show you dual task. So using that's dynamic mode, and then we can use the controllers. So he has to control the bird and go inside the circles, but in the same time he has, sorry, to grab the butterflies coming as well here. So that's dual task, and that's excellent for risk of falls, but for all balance, because balance is not something you have to care about. That's why we thought we had only 5 senses. It's because balance is silent. No one think about balance every day. So it has to become a reflex. So when you try to train people and they know what they are doing, being on foam, being on something that's, they focus on their balance. But while they fall, they never think about their balance. They fall because they were thinking about something else. So that's another key of virtual reality in vestibular rehabilitation, is to bring the patient outside of focusing on their balance. they have something else to do. They think about something else. And so you bring back balance as a reflex, what it should be. You don't have to think about your balance every day, because if you focus on balance, maybe you will be able to cope with the exercises. But when you sleep on something, you won't have time to think about focusing on balance. So then again, here you have all kind of movements. We can add very fast impulses or slow. You can control of all kind of movements, and with the center of pressure here, you can control the reactions of the patient during the rehabilitation. Okay, so we can use VR for motion sickness with or without the motion simulator. Even with just the goggles, it's quite effective. So as you see, the simulation of waves, of course, you can set the height of the wave and the frequency, the time between two waves. And you can add the motion simulator that's perfectly synchronized and that reproduces the actual movements of the waves. The ski, we saw that earlier. Here as well with the bird and the butterflies. Something else important is to minimize the visuo-vestibular conflict while you're doing, I'm just checking the time, I'm almost done. Doing optokinetics or visual flow. So when you're doing visual flow, you have a conflict between the vestibular and proprioceptive system because you're not moving. Proprioception, vestibular, and vision. If you couple the system with this kind of motion simulator, you will have the same movement of the plate as you have in the goggles. So with VR, you can also have a dynamic visual acuity. For assessment, we use just this on the head, so you don't have the weight of the actual goggles moving. It's more precise. But for rehabilitation, we can use the goggles to have 360-degree movement of very fast head movements, because we don't have patients complaining about this kind of movement, what you can do on a monitor screen for DVA rehabilitation, but more about this standing on foam or anything. See, it's actual vestibular stimulation as you have head movements. This one as well is even more effective standing, but you can start seated, then standing, then being on foam. So you see, you can set the difficulty, of course, that's quite difficult with really fast head movements and trying to maintain balance. So again, VR is not only about visual stimulation, but also vestibular stimulation with that kind of exercises. There's quite a lot to do with actual head movements. So my conclusion now, there's an amazing potential, really. We have multisensory stimulation, physiologic conditions, active rehabilitation, and we can control all the settings to make it very progressive for patients. It's one of the tools for vestibular rehabilitation. It's not the only one, of course. We still use, I would say, traditional rehabilitation. Usually my sessions were half. I had my patients for 30 minutes. I used for, let's say, 15 minutes VR and 15 minutes of traditional exercises. The use of VR for vestibular rehabilitation, we have 5 years now, 26 countries, over 100,000 patients, because I know it's a question people ask quite often, but will the patient cope with that? Is it not too strong? We have had over 100,000 patients and not one complaint about my patients cannot cope with it or cannot stand it. It's too difficult. We have almost 500 medical facilities, so it's not commercial. What I write here is to show you that VR for vestibular rehabilitation is installed in a lot of countries for a lot of patients. there are publications now, so it's not the beginning. It's maybe the beginning because it's only 100,000 patients and not millions. But it's really now in France, we have 2/3 of the vestibular PT that are equipped with virtual reality. It's really a must-have the way we practice vestibular rehabilitation. So thank you for your attention. I will read and try to answer your questions now. What are the company manufacture the VR machines? So VR goggles are market VR goggles. We use the HTC Vive Pro because we think it's the best for what we do. And the motion simulator, my company, Virtualis, developed this simulator because it needs to be synchronized with the environment.